Hello students. So continuing our topic of GBS, Guillain-Barré syndrome, we are going to discuss the diagnosis, treatment, and the prognosis of the disease of GBS. So moving forward to diagnosis, as described in the previous video, you already know it depends on two things, the final being EMG NCV and spinal puncture or lumbar puncture. So first diagnosis of GBS depends on finding a rapid development of muscle paralysis, that is areflexia. So first you will check for the clinical aspect, then there will be diagnosis procedures, absence of fever and likely inciting event, CSF, that is cerebrospinal fluid analysis, and electrodiagnosis test of nerves and muscles, such as NCV. Nerve conduction studies are common. Nerve conduction velocity studies are common test order in the diagnosis of GBS. So you already know the lumbar spinal puncture at the level of L4 mainly done. You already know the position and moving forward. In CSF, what will be the findings? So findings include albuminocytological dissociation. As opposed to infectious causes, there is an elevated protein level. So protein level increases, showing there is an infection uh, without an accompanying increased cell count, but cell counts remain normal. A sustained increased white blood cell count may indicate an alternative diagnosis such as an only infection. So the along with protein level, if the white blood cells also increase, it suggests only infection, and which will be initial stage of GBS. When GBS starts already, at that point, only the protein level increases. White blood cell level would have been normal. Moving forward, EMG NCV. So initially you will be able to see prolonged distal latencies. These are the distal latencies. You can see the value 12.9 millisecond, conducting slowing, conducting block, and temporal dispersion of compound action potential is demyelinating casing. So for you, you just remember that there is a prolonged distal latency and the conduction velocity of the nerve, that is ability of the nerve to transmit the signals, will be decreased. That is it that you need to remember. There are certain criteria for diagnosis of GBS. So there are two main criteria that are required for diagnosis. One required, that is important. If these are not there, then it is not GBS. So first is progressive motor weakness of more than one limb. So as we know, it is symmetrical involvement. So more than one limb is involved. And second is areflexia or marked hyporeflexia. The reflexes should decrease or should be absent. If these two are fulfilled, then only go for supportive diagnosis. These are the supportive signs. So first is a progression over days to few weeks, relative symmetry, mild sensory loss, onset with extremity pain, cranial nerve involvement, onset of recovery in 2 to 4 weeks after the halt of the progression. When progression stops, within 2 to 4 weeks, there will be recovery phase. Autonomic dysfunctions, as we know, some types pan-autonomic dysreflexia can occur. Initial absence of fever and elevated CSF protein level after 1 week of symptoms. Abnormal electrodiagnosis with slow conducting or prolonged FF. So you should remember only electrodiagnosis with slow conduction. So if these are also fulfilled, these are the diagnostic features that confirm the diagnosis of GBS. Also some conditions that we have seen like Miller-Fisher syndrome. So here we already know ophthalmoplegia, ataxia and hyporeflexia should be there. Acute sensory neuropathy, here there will be sensory loss first. Other things are normal, areflexia, elevated CSF protein levels, low nerve conduction velocity, we have already seen. Polyneuritis cranialis. Cranialis means involvement of the cranial nerves. So there will be onset of multiple cranial palsies. Acute pan dysautonomia, that is autonomic system gets involved. So acute onset of diffuse autonomic dysfunction with subsequent recovery. Chronic progressive demyelinating polyneuropathy. So here there will be everything. There will be acute onset of weakness, hyporeflexia, slowed nerve conduction, everything, but it persists for more than 6 weeks. When it persists for more than 6 weeks, it will be termed as chronic. And last, chronic relapsing demyelinating neuropathy. So there is a recurrent motor sensory neuropathy with elevated CSF protein level. So an episode will come. There will be signs and symptoms. The patient might need to get hospitalized. He will recover. Once recovery is done, again after following few days, weeks, or months, there will be again an episode, and this will be termed as chronic relapsing. Relapsing means happening again and again, demyelinating neuropathy. These are the variants of GBS and their diagnosis depending on the clinical features. Moving forward, treatment part. Supportive care, important for the successful management of the patient with significant symptoms of greater concern is respiratory failure due to paralysis of the diaphragm. It is life-threatening. The muscle most important for breathing, inspiration. Intubation may be needed when evidence, that is, when vital capacity and negative inspiratory force decreases, and if it becomes normal after giving the intervention, then only it is allowed to stop. So vital capacity and negative inspiratory force should be in the normal ranges. If they go below certain levels, that is less than 20 ml per kg for vital capacity and less than minus 25 centimeter of water, then intubation is required and the patient needs to be intubated. The treatment options available are plasmapheresis and IVIG, that is intravenous immunoglobulins. So plasmapheresis started within 2 weeks of the onset of the symptoms. So filtering antibodies out of the bloodstream directly filter out the antibodies from the plasma. Has done recovery when used within 4 weeks of the onset of the symptoms. So if it is used initially, the sooner it is given, the better are the outcomes. It is used for longer than 5 days, then hepatitis may happen, or in rare cases, renal failure also can happen. So it should be given with precaution. Neutralize harmful antibodies and inflammation causing diseases. That is the function of IVIG. What is the prognosis? So the prognosis recovery usually starts after the fourth week, after a month from the onset of the disorder. About 80% of the patients have a complete recovery within a few months to a year, although minor findings may persist, such as areflexia. So prognosis would be better if it is faster, 5 to 10% recovery with severe disability, with most of such cases involving severe proximal motor and sensory axonal damage with an ability to axonal regeneration. When the axons are damaged, unless and until only myelin sheath is damaged, it will be regenerated. But when axons are damaged, the damage will be permanent. But that happens in only 5 to 10% cases, not majority. Despite all improvements in treatment and supportive care, the death rate is still about 2 to 3%, even in the best intensive care unit. So even if the best systems are given, best hospitals are given, best equipments are used, then also death rate is 2 to 3%. So out of 100, 2 or 3 patients will die off because of GBS. Worldwide, the death rate runs slightly higher, that is 4%. Mostly lack of availability of life support equipment during the lengthy plateau lasting 4 to 6 weeks, and in some cases up to 1 year when a ventilator is needed in the worst cases. About 5 to 10% of patients have one or more late relapses, in which case they may be classified as having chronic inflammatory demyelinating polyneuropathy. So at times the death rate overall in the world is around 4% because equipments are not available for the persons who need them the most, and such 5 to 10% cases may have relapse in, as you have seen in the diagnostic criteria also. Relapsing type of GBS can happen, and that can lead to further decrement. The prognosis of Guillain-Barré syndrome is determined mainly by age. Those over 40 may have a poorer outcome, and by the severity of symptoms after 2 weeks. Furthermore, those who experience diarrhea in the prodrome have a worse prognosis. So the patients who have an autonomic involvement and have diarrhea, which is a common symptom seen in autonomic dysfunctions, they will have a worse prognosis compared to others, those who do not feel autonomic involvement, autonomic nervous system involvement. On the now conduction study, the presence of conduction block predicts poorer outcome at 6 months. In those who have received intravenous immunoglobulin, a small increase in IgG in the blood 2 weeks after administration is associated with poorer mobility outcomes at 6 months than those who IgG level increase substantially. So, in short, the better the outcomes, for better outcomes, IVIG and plasmapheresis should be started as soon as possible. But with precaution, as we know, hepatitis is one of the side effects of the plasmapheresis treatment. So this is it about medical aspect. Physiotherapy aspect will be discussed in the forthcoming lectures because it will require complete assessment and the video would be stretched to a longer extent. Hence, thank you for listening. Listen to it again if you do not, if you have any doubts, you can ask in the lectures that we are proceeding after this. Have a good day. Be safe.